sutures and whatnot.
You can take out sutures.
It's probably my most favorite thing to do.
Wait, are we able to like certify something where we could do sutures or?
Like sutured myself.
Okay, that's a plus.
Last week.
Alright guys, we're at 1 o'clock. So let's start with a brief devotional. It's okay. You looked very intently discussing something, so.
I was upset about it last week.
Oh, what happened?
It was at work. That was all. It had nothing to do with school.
Oh. Well, I apologize for your bad experience.
Okay, thank you.
I realize I probably had nothing to do with it, but
No, you did not. I appreciate it.
I sympathize. Proverbs 17:22 says, "A cheerful heart is good medicine, but a crushed spirit dries up the bone." Make a conscious effort today to brighten someone else's day. Let's be cheerful to impact others positively. Let's find our joy from the Lord. All right. Any prayer requests before we get going?
Next week, I just feel like I'm gonna be really tired, and I have 4 12-hour shifts next week. And I didn't realize it when I was planning it, but I have my last 2 preceptors and then our ICU, so I'm like, that's gonna be really tiring, but I'll be fine if I eat well.
That's a lot.
It's okay. As long as we don't have a test the next week, I'll be fine.
We did.
Don't.
I was with
Okay. She said it's
and then if we move exam for
Okay, well,
exam for is like
we're gonna.
more to come. Pause. Let's pray, and then
Let's make exam 3
let's
next
talk.
week.
Hold on. No. Pause. Father, thank you so much for this day. Thank you for letting us come together and learn more skills and knowledge as they're getting ready to go out into the world as nurses. I pray that you will be with these students. I pray that you will give them the strength they need to get through the rest of this semester. I pray that you will be with Karis as she has a very busy week next week. And I pray that you will rejuvenate all of these students because I know this semester is really rough. In your name I pray. Amen. All right. So, I had a meeting with Dr. Giles and Nathan, or Professor Napier and Professor Petty on Monday, which is why I wasn't in here to proctor your exam. And the goal of that meeting was to make this class more manageable for you and for me. Because I have been drowning, this material is very heavy, and I don't feel like you need to know it all, period. This is not, I think it was designed to be an ICU class. Not all of you are going to work ICU. That's why I've kept on saying, don't get bogged down, don't get bogged down, but I still feel like you're getting bogged down, okay? All of this being said, throw out your old calendar, it's useless. Okay, here we go. This is your new
Is this
calendar.
on Brightspace?
No, not yet. I didn't post it because I didn't want you all to panic.
Okay.
I remember what being a student is like. I know if I had seen that, I would have been like, holy cow, what's going on? I didn't post it. So take a deep breath, it's for the better, okay? Today we're going to be covering the ECGs, and I've really tried to line it up so it goes along with the assignments that are still in there. We're still going to do those, okay? That being said, the class is getting changed up just a little bit because I want you to do those so that you have that education and so that you have those points. Because if you do them, it's a give me point, right? I mean, completion grades. Who doesn't love a completion grade?
You're talking about the assignments on platform.
Elsevier, yes. Now, next week we're going into SHOP. Everything that is on this calendar, it isn't completely comprehensive. Like I'll be throwing a few other things into these days, but it will be more manageable, okay? After that, we will go into endocrine, and then on the 4th is your exam 3. That's probably the most important thing for you to know at this time. The 4th is exam 3. Then we're in the
March
week,
4th.
yeah, March 4th.
Oh yeah, March is the next month.
Yeah. And that that March exam will just cover ECGs and shock. It's not going to pick up that endocrine information yet. So it's just the ECGs that we go over today.
So it's not, wait,
It should be Digi's presentation is the paper.
okay, so it's like that?
Right
So
here.
that one's being moved to forward?
Throw out your old calendar, girl. Ignore it. Old calendar's gone.
Yay.
I will post
ECGs
this.
and shock.
Yes, and I actually wrote it on this template too. So when I upload it, it will be in your possession. But again, I didn't want to freak you all out. After we do the exam, the next week is going to be some more endocrine, and we are going to get the pulmonary just a little bit, and then we'll have spring break. When we return from spring break, we're going to do some more pulmonary, talk about respiratory distress, talk about ventilatory care, and then we'll come and do exam 4 on the 30th. So very end of March, we'll have exam 4. And then when we come back from that exam, we'll do neuro, so we'll work on seizures, stroke, traumatic brain injury. We'll do burns, and then exam 5 will be 415, and that will cover neuro and burns. We'll finish up the semester talking about acute abdomen, GI bleeds, and then you'll have your final on 4/27. I think we said 9 o'clock, right? Yeah, because I told you I'm not coming in at 8. Yeah.
So no exam 6.
No, exam 6. We got rid of an entire
All right.
exam.
Yay!
That gives
That
only
gives more time for a final.
Yes.
Exam 4, what date was that? March 30th?
Yes, sir.
And then exam 5,
Is 415,
So where's the other 100 going?
right here.
The final.
But the final was already 100.
The final is
It's
200.
200.
Yeah.
Yeah, but if you took out exam 3 and
that's
exam
March
6, that's
11.
200 points.
we did take out exam 3.
No, we didn't.
We only dropped 1 exam,
Oh,
because there was
okay.
supposed to be 6 initial.
Exam 3 is on March 4th.
We just shuffled. We shuffled points and we shuffled exams. Professor Napier recommended that I take out 2 exams and make each one 150 points, and I really thought about it, and I said that's really not fair to you all. I feel like that makes them too high stakes.
Yeah.
My final will be based on what you're examined upon.
The exam
I don't
is-
intend to make new questions for that final. I'm going to be pulling questions from your other exams. So keep your study guides, keep that, okay? Maybe that will decrease your stress levels just a little bit. Because again, I don't intend to make new questions for those exams.
So the content of the exams has changed. Like, are you going to be focusing in more on specific things and leaving out
A bunch.
a bunch of other stuff? But you'll have time in class to actually focus in on specific things that you think are important, correct? Okay.
That is correct, that's the goal. Because trying to make it through that textbook and hit everything that the textbook thinks is important is just too much. It's too much. I'm done. We're not doing that anymore. I'm done with that game. It's not been fun.
I'm glad you changed things up, because up until this point, I've just been relying on med surg from a couple of years ago. I gave up with this class. I was just like, med
Yeah.
surg, we'll do
No,
this.
I feel like, if I feel like I'm drowning, I can't imagine what it's been like for you all. Now granted, I'm going to be making this as we go. I was making it as we go anyway, but it's going to be even worse. So, I finished our lecture today, last night about 10:30. Like when I uploaded your stuff, that's when I was done. So,
You said.
Jeez.
and then I added some more stuff this morning, in between the other class and like right now.
Our rhythm strip test, or rhythm strip quiz, do we still have that on the
You do still have that.
on the 24th?
Yes,
Okay.
but it's on your own time.
Yeah.
Like, you don't have to be in here to do it. That is you on your own. Yeah. But I'm hoping today will be helpful in getting you ready for that. And keep in mind, it's only on the stuff that is posted in Brightspace.
Oh, are you talking about the announcement you posted?
the rhythm strip quiz is like a 20-point quiz that's on your own. It's only on the rhythms that are in Brightspace.
Okay.
Yeah. And I did not change that date. So what it was initially listed as, I think it got deleted off of this calendar. So I'll try to remember to add it back in before I post to this, but I'll post this afternoon. Other questions?
All the homeworks on Elsevier are still out.
Still as is.
Yeah.
I didn't want to change that. And Elsevier is very difficult to work with. It's hard for me to go in and change something. So if anyone's touched it, I can't change it anyway. So I thought, okay, just leave it as it is. But I did try to match it up with what we're going to be talking about in class moving forward, broadly. But let's take like a 100 feet, 100 feet away view, broadly. Questions? Concerns? Are we happy or are we angry? Happy?
No, I couldn't be.
Thank you.
I have nothing to do about that.
Okay.
So basically all you did was move exams, right?
No.
No, she moved everything.
So the content that was going to be covered was chapters, like specific chapters, intending to get really intense into the chapters.
Right.
No, we sat down and we discussed what's the most important thing for me to impress upon you.
Okay.
So
So it's less chapters now.
not necessarily fewer chapters, less content from the chapters.
Okay.
Is that more clear? It's kind of what can we teach to teach you the most important critical topics that you need to know leaving us. So yeah, you may have talked about GI bleeds in the past, but what are we going to do about them? So it's going to be like a review of giving blood. It's going to be a review on hemodynamic monitoring. What are you really concerned about? Have y'all ever seen a GI bleed?
Mm-hmm.
Holy cow, it can be bad, and it can be bad really fast. And they crash very fast. So we are marrying ICU and ER. That is what we are doing now. Because I'm done treating this like ICU as the epitome, the end all be all, because that's really not what this class should be. Questions? No? Okay. Now we're gonna also try to change some things up just a little bit today. If I can get my mouse back. I have a video. Yay! I'm excited. But we do have a little bit of PowerPoint before we hit the video. And she does a really, really good job of kind of reviewing the electrical function of the heart. What?
The purple nurse. That's what Professor Lombard called it.
Purple immerse.
Oh, well, her initial videos were horrible. Like if you sit down and scroll down to like the very beginning of her making videos, they were really awful. But the newer ones are actually really good, and I like that it has the kind of, they're not really interactive diagrams, but they're actually like functional videos of what happens electrically within the heart. So if you're not like an auditory learner and you're a more visual learner, I think this would be helpful. Okay. So let me start my PowerPoint, which I did post last night. At the beginning. There we go.
You made this PowerPoint?
Yeah, I made the images, but I did the rest.
But you made the PowerPoint?
I did.
Okay.
I didn't
It's
pull it
not
from
their-
Elsevier. No.
Awesome.
There will be no more Elsevier PowerPoints.
Yay!
I hate them. I hate them, I hate them, I hate them. Yes. They're awful. Like, they're horrible. So, here we go.
What chapter are we in?
We're in a mix of chapters.
A mix.
Yeah, roughly 12.
Okay.
Roughly 12. 12-ish. 12 adjacent. We'll call it that. All right. So the sinoatrial node, the SA node, is the heart's natural pacemaker, and it initiates impulses that cause atrial depolarization. What is atrial depolarization? It's where that atria contracts. right? So the electrical impulses then travel to the atrioventricular node, or AV node, where conduction is briefly delayed to permit emptying of the atria and filling of the ventricles before those ventricles contract. So what would happen if that... Are we laughing? Are we okay? So what would happen if we did not allow the atria to fully empty?
The contraction of the atria wouldn't allow for complete filling of the ventricles.
Not only that, but we also wouldn't have blood in the ventricles to pump out of them, right? So they would just be empty. There wouldn't be anything there. That is why we have the AV node. The AV node says, hold on a second, let's let the ventricles get full before we progress. So from there, the impulses move rapidly through the bundle of His and the Purkinje fibers, and this results in a coordinated ventricular depolarization and contraction. And any disruption in this electrical pathway of the heart can result in dysrhythmia. When we're talking about heart rhythms, we have to consider electrocardiography. So electrocardiography uses an electrocardiograph to record the electrical activity of the heart over time. And the electrocardiograph is connected by wires to skin electrodes placed on the chest and limbs of the patient, and then it translates the heart's electrical activity into waveforms. You've seen this. I know you've seen this because I've been with you when you've seen this. We've done EKGs in practice. Some of us have initiated telemetry on patients. This lets us know what that heart is doing electrically. That is what we are looking at. We are looking at the electrical activity of the heart when we look at telemetry and when we look at 12-lead ECGs. The P wave represents atrial depolarization. The QRS is ventricular depolarization, and it actually hides atrial repolarization in that QRS. Just because that electrical activity is so strong, we don't see the repolarization. The T wave shows ventricular repolarization, and that is it. That is all that we're going to see unless there are some really outlier changes in the electrical activity. We also look at the intervals, like the PR interval. This represents AV nodal conjunction. We look at the QT interval, which reflects the total time the ventricle takes to depolarize and repolarize. Deviations in any of these waveforms or intervals can indicate conduction delays, ischemia, electrolyte abnormalities, or any kind of medication effects. So now we're going to look at a more visual representation of this, if I can get back to it. There she is. Okay. Sound was a little iffy, so let's see how it goes, because I tried it while I was waiting on you all to come.
Hey everyone, it's Sarah, the registered nurse, RN.com, and in this video, I'm going to be going over EKG interpretation basics. And as always, whenever you get done watching this YouTube video, you can access the free quiz that will test you on this material. So let's get started. An ECG, also known as an EKG, stands for electrocardiogram. And an electrocardiogram assesses the electrical conduction system of the heart. And the whole role of the electrical conduction system is to get your heart to contract and pump blood throughout your body. So to help us really understand how to interpret an EKG, we first have to go back to the basics and talk about how the blood flows through the heart and apply that to how the electrical conduction system causes that to happen. So first, let's look at the heart blood flow. Everything starts on the right side of the heart, and blood that needs to be replenished with oxygen will enter into the right atrium. When the right atrium becomes full, it will be stimulated by the electrical conduction system and cause it to contract, and it will send blood down through the tricuspid valve into the right ventricle. The right ventricle will become full, and whenever it receives stimulation from the electrical conduction system, it will contract and send blood up through the pulmonic valve into the pulmonary artery, where the blood is going to go into the lungs and gas exchange is going to occur, and then that blood is going to get oxygenated again. Enter in to the left side of the heart through the pulmonary vein. It will go down through the left atrium. Left atrium receives the electrical signal to contract once it's full, and it will contract and send the blood through the mitral valve into the left ventricle, and the left ventricle will contract whenever it receives signal up through the aortic valve and into the aorta, and then it will go through your body and replenish your tissues with fresh oxygenated blood. But in order for this process to occur smoothly, we need the electrical conduction system to send off these electrical signals that target the cells of the atria and the ventricles so they will contract and relax. So, in order for the electrical conduction system to do this, it has to cause repolarization and depolarization of these specialized heart cells. So these are two terms that you really want to make sure that you understand whenever you're studying EKG interpretation, because they really lay the foundation for understanding this PQRST complex. So here I have a heart cell. It's resting, meaning it's not really doing anything. It's just hanging out until it's told to do something. So whenever you have a resting heart cell, it is negatively charged on the inside, and we can refer to this as it's being polarized. And this cell, the reason that it's like that is because there's a different concentration of ions on the inside compared to the outside. And this cell membrane around the cell is really not permeable right now. It's impermeable, specifically to sodium. There's a lot of sodium outside the cell, and it would love to get on the inside. So whenever this cell receives a jolt of electricity from this electrical conduction system, it really changes that cell membrane and causes it to be more permeable. So that sodium's like, hey, I can get inside that cell now. So the sodium goes inside the cell, and it changes its state from being negative to less negative, so a little bit more positive, because sodium's positive, and it causes depolarization. And whenever the cell becomes depolarized, it causes it to contract. So the next step after contraction is relaxation. So after we have contraction, it relaxes, we get repolarization, it's going back to its negative state. So what you want to take away from this is that depolarization leads to contraction. So whenever I'm saying atrial depolarization, I'm talking about atrial contraction, the contraction of the atria. Whenever I'm talking about repolarization, I'm talking about relaxation. And to help you remember that, to keep those two straight, remember that the word relax starts with RE, repolarization starts with RE. So whenever I refer to ventricle repolarization, I'm talking about the relaxation of the ventricle.
Hello.
Sure, you'll get up with your groceries.
So now let's look at the specific parts of the electrical conduction system. Normally, everything should start here in the SA node. The SA node stands for sinoatrial node, and it's located in the right atrium in the upper part of it. And we like to refer to this as the pacemaker of the heart because it causes your heart to beat at a rate of 60 to 100. Now, the SA node is responsible for making the atria contract. So it causes, when it fires, it causes atrial depolarization. So whenever the electrical signals leave here, goes through these internodal pathways. Over here we have a pathway so it can actually get over here to this left atrium because it's a little bit over there, called Bachman's bundle. And then it goes down and hits the AV node. AV node, that stands for atrioventricular node. And we refer to this node as the gatekeeper. And why do we call it that? Well, the AV node helps delay or slow down impulses for just a little bit because it's allowing these atria to fully empty themselves and allow the blood to go into the ventricles. Because we don't want there to be leftover blood in the atria before the ventricles contract, and we don't want the atria and ventricles contracting together because we would have problems. So, signal will leave here, it will go down to the bundle of His. So now we're ready for ventricle depolarization. So what's that going to lead to? That's going to lead to contraction of the ventricles. So it goes down through the bundle of His. It's going to go down through the bundle branches. You have right bundle branch, you have left bundle branch, and then it's going to hit the Purkinje fibers. So Whenever this system occurs, the electrical conduction system shooting from SA node all the way to Purkinje fibers, we can pick this up and we can look at it. And we can see it as our PQRST complex. So if everything's occurring normally like it should, everything's coming from our SA node, originating there, it's firing the way it should, we should have on our EKG strip a beautiful normal sinus rhythm with all of its parts measuring perfectly and forming perfectly. But if there's an issue with this system, we can get dysrhythmias. We can get like atrial flutter, atrial fibrillation, VTAC, etc. So now let's see the heart in action, how it actually contracts and relaxes whenever it is stimulated by this electrical conduction system and creating this PQRST complex by looking at this animation. First, the SA node fires, and this causes atrial depolarization, which causes the atria to contract. Then the signal goes down to the AV node. And notice the AV node does not fire until those atria are empty and the blood is in the ventricle. Then it's time for ventricle depolarization, so the signal travels down through the bundle of His to the bundle branches, and then the Purkinje fibers causing ventricular contraction, followed by the relaxation of the ventricles. So now let's look at this PQRST complex in detail and apply it to EKG strip paper. Now whenever you're analyzing a patient's rhythm and you're trying to interpret what kind of rhythm this is, you're going to have a lot of these PQRST complexes, or EKG, on EKG strip paper. And you want to be familiar with the EKG strip paper because it's made up of small boxes that are contained within large squares. And each box represents a measurement of time. And whenever you're starting out analyzing these rhythms, you want to be familiar with the basics, like how to measure certain parts of this complex, what each part of this complex should look like. Is it regular, irregular, its rate, and so forth. So I want you to memorize the following information. On this EKG strip, each small square that you see represents 0.04 seconds of time. And each large square, it contains 5 small squares. So it represents 0.20 seconds of time. And the reason you want to memorize this is because you will be analyzing these small squares to determine the duration of certain parts of that PQRST complex.
I tried a ton of AI workflows. Then I tried Monday.com. Game over. Monday.
Next, you want to memorize the PQRST complex and all the little extras found within it. So first, let's look at the P wave. The P wave represents atrial depolarization. So this leads to the contraction of the atria, which is created by the SA node. So whenever those atria contract, it creates this little wave. Now, right after the P wave and before the QRS complex, we can find the PR segment. And the PR segment demonstrates the delay the AV node created. Remember, it was the gatekeeper, so it gave the atria time to dump its blood into the ventricles before the ventricles contracted. Also found in this area is the PR interval, and I really want you to remember the PR interval because we measure this, and it's very important in determining if your patient has a heart block. So the PR interval starts at the beginning of the P wave and extends to the beginning of the QRS complex, so it's different than the PR segment. PR segment was after the P wave. The PR interval is before the P wave to the beginning of the QRS complex. And this demonstrates the amount of time it takes for the electrical signal to go from the atria to the AV node. And if it's taking too long, if we have a long PR interval, this could indicate a heart block. Next is the QRS interval, or also known as the QRS complex, and this represents ventricular depolarization. So this is leading to the contraction of the ventricles. Also found in this, but you can't see it, is atrial repolarization, where the atria are relaxing, but the ventricles are so large that whenever the atria relax, it's overshadowed by the ventricles, so you're really only seeing ventricle depolarization here. Then we have the J point, and this is the point where the QRS complex meets the ST segment, and the ST segment represents the completion of ventricular depolarization and the beginning of ventricular repolarization. And this segment should be flat, hence it should be isoelectric, meaning flat. So there should be no depression of it or elevation. And isoelectric is a word that is used to describe straight across lines of the PQRST complex that represents that the heart cells are resting. They're not contracting and causing electrical activity, so none's being transmitted to the EKG. Then here we have the T wave. The T wave represents the beginning of ventricular repolarization, so relaxation. And the ventricles are so big that whenever they relax, it creates this T wave. And then after the T wave, you usually have a flat line, which is representing ventricular repolarization is complete. It's a flat line, isoelectric. And then the cycle starts immediately again, where you get a new P wave, QRS complex, T wave, and it just keeps going on. Now, sometimes after the T wave, you may see a U wave. It's not the case in a lot of patients, but in some patients, and it may be happening because your patient's potassium level's low, like in hypokalemia. And then lastly, here is the QT interval. The QT interval starts at the beginning of the QRS complex and ends after the T wave. And this demonstrates the time it takes for electrical signals to cause the ventricles to contract and then rest.
An IQ of 85 to 115 is considered average in the U.S.
So now let's recap all that information and look at this PQRS.
Okay. So hopefully that gave you a visualization of how that influences the EKG. Okay, how that influences the development of the P wave, the QRS interval. Yes.
I missed what you said the RT segment was.
So I'll be really honest. That's not something I want you to be concerned about. I want you worried about the P waves because we're going to be looking at that PR interval. If it's prolonged, then we have a heart block. I want you knowing what an ST elevation is because what does that indicate?
Well, a number of things, but most importantly, it might indicate an MI.
An MI, correct. Yeah, and that's,
It could be a number of things.
I mean, it could be other things, but what do we care the most about? MI. What do we need to acknowledge quickly? An MI. I mean, that is really what I'm most concerned about. That link is on this slide. If you care to watch it again, we're going to finish a little bit more of that video in just a few minutes. So a rhythm strip is an ECG recording that captures the atrial and ventricular activity. And it's a method of enabling arrhythmia detection and assessing for conduction delays and identifying ischemia in the instances of the ST elevation. So there are a few different kinds of ECG recordings. There's the 12-lead ECG, which is very specifically a snapshot, an instant of time, and it's capturing the heart's electrical activity in that time period from multiple different directions. It's really useful when you suspect ischemia, infarction, or some kind of conduction delay, and this is because there are multiple leads that give you a very complete picture of a single rhythm strip. So when we're obtaining a 12-lead EKG, what does the patient need to do?
Sit still.
Sit still. Should they be talking? No, because that can make alterations in the tracing of that EKG. So make sure the patient is still, make sure that they're breathing normally. If they're breathing rapidly, that's going to impact the tracing of that EKG. You also need to make sure that they're quiet, and they typically hate to be quiet. So just say, hey, hold on just a second. Let's be quiet for just a minute. We're trying to get this EKG, and then we can keep talking. Continuous cardiac monitoring requires the patient to be in close proximity to that monitoring system. This is bedside monitoring, and the patient is hooked up to the very large cardiac monitor at bedside. You've seen this. I know you've seen this because we saw it at Wright.
It's just the 5 leads.
It's the 5 leads that is letting us visualize that ECG tracing while they're physically attached to it. If they have to go to the bathroom and we detach them, we lose the ECG tracing. Telemetry allows the patient to walk around while maintaining proximity to a central monitoring system. And this telemetry is typically a wireless system where the patient has wireless Bluetooth monitors that transmits to a centralized monitoring system. So essentially they wear the telemetry in their pocket, and then they're able to get up and walk around and move around. Their ECG tracing is still captured, but they don't have to be physically hooked into the monitor system at all times. This is a great system. They use this, I don't know if they use it at Ray, but I know they use it at places like Erlanger
Are you
Memorial.
talking about like the little?
Little,
They have
Yeah,
the
we
little
have-
box in the
okay.
pocket.
Yeah.
yeah.
Was it
I
not
just-
plugged into the wall? No? It's just the
I
box?
used to hook those bad boys up all the time.
Yeah, so they can get on and walk around, and we still can visualize their ECG tracings, but they don't have to be physically hooked into the wall like they are in the emergency department there.
And that's called telemetry. Or
Yeah. So as a nurse, it's important that you educate the patient that this system will not detect chest pain or shortness of breath. So it is the patient's responsibility for them to let you know if they're having any changes, if they're experiencing the chest pain, if it's new, if it's changed, if they're starting to have worsening shortness of breath. And then you can also monitor for physiological changes that you can visually see that can be associated with dysrhythmias. So altered mental status, visually seeing the patient struggle for breathing. All of that can be associated with dysrhythmia findings. So on the ECG paper itself, it measures both time and voltage. The time is on the horizontal axis. What is the horizontal axis? What does that mean? It's the axis that goes left to right. Remember, think of it like someone laying on their back and they're sleeping. They're having Z's, right? Little Z's. That's how I learned it as a child. It's horizontal. That right there is your time measurement. This is your vertical axis. This measures voltage. So if you look closely, that paper is composed of 5 small boxes within a very large box. So there are 5 boxes horizontally and 5 boxes vertically. So theoretically there are 25 in each large box, right? Yes. When added together, this means that large box is 0.2 seconds. So it's 0.2 of a second. Think about how short of a time period that is. 0.2 of a second. And when we are looking at like heart rate, we want to make sure that we're looking at a 6-second interval in order to calculate that heart rate. So that 6-second interval will be a total of 30 of those large boxes. So when you're calculating heart rate on that quiz that you'll be taking, you'll want to see, okay, 30 of the large boxes can help me calculate the heart rate. And we determine that rate by counting the QRS complexes in those 30 large boxes in that 6 seconds and then multiplying by 10. Why are we multiplying by 10?
Because there's 6 and 60 seconds.
There's 60 seconds in a minute. So if you have 6 seconds, the 30 boxes, and you multiply that 6 seconds by 10, then that is 60 seconds or a minute. Next, we have to look at that ECG and determine, is the heart rate regular? Is it consistently on that ECG tracing, or are they irregular? So you're looking to see if the complexes are equidistant and if they're predictable. You're going to look at those P waves for regularity. So are the P waves regular across that ECG tracing? You're going to look at the PR interval for length. So the length of that PR interval should be about 0.12 to 0.2 seconds, or about 3 to 5 of those little teeny tiny boxes. Not the big boxes, the small boxes. Next, you need to make sure that you're measuring that QRS duration, and you're looking for consistency in appearance. So are they equidistant? Are they occurring at a rate where you can actually visually see it? You need to see kind of what their width is. So the QRS width should be about 0.08 to 0.11 seconds. So that is 0.08 to 11 hundredths. I guess that's 11 hundredths. So you're going to look at that. But again, that's just about 2 small boxes. You're going to look at the T wave. Is it upright? Is it inverted? And then you're going to look at that QT interval and you're going to see, is that QT interval, is it elevated? Is it depressed? And that QT interval should be about 10 small boxes or about 4/10 of a second. So now we're going to flip back to our lovely little,
The QT interval is from the J point to the end of the T.
your QT interval is actually from the initiation of your QRS. So if you look down here, do you see my mouse?
Yep.
So the initiation of the Q to the end of the T wave. How did I get her back? I've lost my mouse. Now let's actually see what this looks like on an ECG tracing.
Complex and see how depolarization and repolarization is occurring in each part of that complex. So here, section 1 is the P wave. That represents atrial depolarization beginning. So we have the contraction of the atria. Then 2, that was our PR segment. That was atrial depolarization complete, so it's done. Then 3 was our QRS complex, and it represented ventricular depolarization beginning. And in there, but you can't really see it, is atria repolarization. It's relaxing. Then 4 is our ST segment, and that is ventricular depolarization completing. Then we have 5, which represented our T wave, and that is ventricular repolarization beginning. And then 6 is that flat isoelectric line, and this is ventricular repolarization complete. So now that we've identified all the parts of the PQRST complex and where repolarization and depolarization is occurring, let's now talk about how each part should measure and what each part should look like, because this will help us analyze a rhythm. First, let's look at the P wave. So P wave should always be present in a rhythm if it's normal. And there should be one P wave in front of one QRS complex. And they should be up like this, they should be round, they shouldn't be flat. And their measurement should be less than 0.12 seconds, so no more than 3 squares. So whenever you're looking at the P wave, look at those squares that it's taking up and count them, because remember, each small square represents 0.04 seconds. Next, look at the PR interval. The PR interval, again, starts at the beginning of the P wave and extends to the beginning of the QRS complex. And you're looking at its measurement. It should be about 0.12 to 0.20 seconds, so about 3 to 5 boxes. Any more than that, you may be thinking heart block. Here we have a picture of a first-degree heart block, and notice that that PR interval is more than 0.20. Next, look at the QRS complex. It should be behind every P wave, and it should look like this. It shouldn't be very wide or narrow. Here we have VTAC. Notice how wide that QRS complex is. Whenever you measure it, it should be no more than 0.12 seconds, and you want to start measuring at the Q wave to the end of the S wave. Then there's the ST segment. This starts at the end of the S wave and stops at the start of the T wave. It should be flat, shouldn't be elevated or depressed. And if it is, it should be no more than 1 millimeter. And here is an example of an abnormal ST segment. Here we have ST elevation. Here we have ST depression. Followed by this is the T wave, and the T wave should come after the QRS complex and should be round and in the upright position in most leads. And lastly, the QT interval. With this, you're looking at the measurement. Typically, it's anywhere between 0.35 to 0.44 seconds, and men have shorter intervals than women, and it really varies depending on if it's a fast heart rate or a slow heart rate. Fast heart rates have shortened QT intervals, and a prolonged one could increase the risk of ventricular dysrhythmias, like torsades de Plante. Now,
Imagine being able to build an app with your name on it, just by thinking about it. Meet Base 44.
now let's apply this information we have learned about this PQRST complex and analyze a rhythm. So to do this, you want to use an EKG strip that's at least 6 seconds long.
Okay, so 6 seconds, 30 boxes, right? Okay. I wanted to review all of that with you so that you can be a little bit better prepared for that quiz that you have. Yes.
When you print out a 12-lead
Mhm.
ECG, is each of those leads represented by 30 boxes there, or they seem to be a little shorter than 30 boxes?
They should be.
They should be
They
30
should be.
boxes? Okay, so you can just look at that.
Mhm. And then you can do your calculation.
Are we going to be doing that on the quiz, or are we just identifying like what rhythm?
You're just
students-
identifying the rhythm. But
Okay.
sometimes you have to do the calculations before you can actually really identify what the rhythm is.
Right.
Yeah. But I wanted to review, I don't know if you've covered this, I have no idea. I don't know if you've seen this before or have received this information.
We had some of it in Professor Lobach, but I never really understood it fully.
Okay, and I feel like that video is very helpful in explaining it
Yeah.
because she actually shows you why that tracing is showing up on your ECG. Although I may verbalize it, if you see it happening, I feel like that makes just so much of a difference. Because I guess I'm a visual and auditory learner, so I need both. So moving forward, here is a 12-lead tracing, right? The 12-lead EKGs. If you look at the top, you can see your heart rate is calculated for you, right? Typically at the bottom, Caleb, there is going to be a longer of the 2-lead number 2 down here, and that should be the
30.
entirety of the 30. Yes.
Okay, because all
These
the rest
are
are just
not.
12 long.
Yes.
Okay.
This one will be. It will be at the very
So
bottom.
the very
It's
bottom one.
just not on this one.
And which lead is that?
It usually is lead number 2.
Okay, so the
So
favorite
we
one.
usually, yeah, the preferred one. And that's why, because we like to analyze lead number 2, and then we take this and we put it down here. But tips of the trade. Do you see up there at the very top, it says heart rate 77 beats per minute? That is pretty accurate at calculating your heart rate. If you're in practice and you see those numbers up there, don't look at the reading itself. The monitor is terrible at reading EKGs, but it is a computer, so it is good at calculating the numbers. It is good at calculating the heart rate. It's good at identifying that PR interval so that you don't have to carry around calibers in your pocket. What she was using. That is called a caliber. It looks like how were the things, you know, you use it to draw, no,
Wait, no,
the compass that you use to draw the circles when you're in geometry. Well, in cardiology, they're called calibers. And I don't want you to have to carry that around in your pocket. So it establishes your PR interval for you. 0.16 in this one. Normal? Yes. Your QRS interval. 0.084. Normal? Yes. So we have normal sinus rhythm because we have a P wave before every QRS complex. The QRS complexes appear to be pretty regular on their intervals. And then we have, yes?
So you said, I can't really read that middle section, so it has the lengths of your PR interval and
You're talking about very shortly. Right about here,
Yes.
it's your heart rate and your PR.
Mhm.
And then right here is your QRS.
Okay.
And it's on all of them, which is fantastic. Can I switch to the next one? Okay. All right. So now we're going to look at sinus rhythms. Normal sinus rhythm is a rate of what?
60 to
60 to 100. They're at regular intervals. They have uniform P waves that precede each QR complex. And that PR interval is normal, measuring 0.12 to about 0.2 seconds, and it stays constant. The QRS complex is narrow, about 0.1 to 0.11, and that lets us know that ventricular conduction is normal. Sinus bradycardia meets all of the criteria for normal sinus rhythm except the heart rate is less than 60. Exactly. That rhythm is still regular, the P waves are still present, and the PR and QRS intervals remain normal. Sinus bradycardia can be normal in certain situations, such as in individuals that are young and they're well-trained athletes, and it can also be normal during sleep, but it can occur during increased vagal tone, Medications like beta blockers, where our heart rate is slowed from the medication impact, or an intracranial pressure that is increased. Sinus bradycardia does not always require treatment unless the patient is showing signs of poor perfusion, like hypotension, dizziness, chest pain, or altered mental status. What is the first treatment for sinus bradycardia? What medication do we give? Atropine. So we try atropine first. If the bradycardia is not resolved, then what do we place? A pacemaker to make sure that the heart is paced at normal sinus rhythm moving forward. And that's only in symptomatic patients. And usually the pacer is placed when it is significant sinus bradycardia. Sinus tachycardia meets all of the criteria for normal sinus rhythm except the heart rate is greater than 100 beats per minute. So the rhythm is regular, the P waves are present, they're before each QRS complex, the PR and QRS intervals are normal, and sinus tachycardia is typically a response to something else going on in the body. Common causes include exercise, pain, fever, anxiety, hypovolemia, hemorrhage, heart failure, hypoxia. It's important to remember that sinus tachycardia is usually compensatory. The heart rate increases to maintain the cardiac output, and because of this, we can't just treat the tachycardia itself, we have to treat the underlying cause. Why is the tachycardia happening? That is what has to be treated. So if it's related to fever, we're treating the fever. If it's related to dehydration, we're rehydrating the patient. If it's related to anemia, we're giving blood products. We're treating the anemia. We can't just treat the tachycardia. Moving on to the atrial dysrhythmias. So atrial dysrhythmias occur when the atria fires at an impulse earlier than the SA node normally would. So because this impulse starts above the AV node, it usually produces a narrow QRS complex. Atrial flutter is recognized by a very characteristic sawtooth manner, which is this in the left-hand side. Do you see that it looks like saw blades? Have you ever seen a saw, like a circular saw? Or one of the old straight saws where you would cut the logs. You had the loggers cutting down the sequoia forest. Looked like this. These are called flutter waves. It's because the atria are being stimulated over and over in a rapid organized loop. This rhythm is caused by a reentry circuit in the atria, and the electrical circuit repeats itself over and over and over again. The atrial flutter is very regular, and the rate is typically fast, about 250 to 350 beats a minute. And the AV node protects the ventricles by blocking some of these impulses to the ventricles. So not every flutter wave results in conduction to the ventricle. Therefore, there is not always a QRS after every P wave. Medications like amiodarone or sotalol can be used for rhythm control in atrial flutter. And this works by slowing conduction through the AV node. If the patient is hemodynamically unstable, electrical cardioversion is the treatment of choice. So if they're hemodynamically stable, they have normal blood pressure. If they're not exhibiting signs of distress, we start with medications first. If they are unstable, then we cardiovert them. For long-time management, sometimes a catheter ablation has to be implemented in order to kind of burn that part of the heart that's taking over the SA node and causing that flutter of the atria. In atrial fibrillation, the atria do not depolarize in an organized way. Instead, there's a lot of chaotic electrical activity coming from multiple sources in the atria, and this caused the atria to quiver and contract ineffectively. So if you look at the bottom right-hand side, that's what atrial fibrillation looks like. And guess what? These images that I used, If it's on your quiz, it's the image that's on your quiz. There you go. There they are. Know your images. Yay, right? They'll be uploaded. I know you just took a picture, but they'll be uploaded.
When I printed it off, it cut the top one off.
It's not.
No, the top one's what I added while I was in between classes. Yeah, so no worries. I'll re-upload it.
Thanks. I thought I just cut it off.
No, it was me thinking, oh my gosh, I didn't remember to add SBT. They need to know this kind of after the thought. So, on the ECG, atrial fibrillation is identified by no identifiable P waves. It's just kind of wiggly. There is an irregularly irregular rhythm. And there is a fibrillatory baseline that looks uneven or wavy. That atrial rate is extremely fast and uncoordinated, usually more than 350 beats a minute, and this makes it just impossible to count. That AV node is acting as a filter, allowing only some impulses to reach the ventricles, and this creates that irregular ventricular response. The QRS is narrow, but it can be rapid. Over time, atrial fibrillation can cause some structural changes in the heart, like atrial enlargement and fibrosis, and that makes it even harder for the rhythm to be reversed. When we're managing atrial fibrillation, we're looking at two different strategies. We not only have to control the rhythm, but we also have to control the rate. Rhythm control focuses on converting that atrial fibrillation into sinus rhythm by using medications or cardioversion. And the rate control focuses on slowing the ventricular rate while allowing patients to remain in atrial fibrillation with things like beta blockers, calcium channel blockers, and digoxin. Yeah.
What is our main concern for a patient with AFib? Is it developing a clot and throwing up?
Yes.
Is that
100%. That is what we're most concerned about. Because that atria is quivering, it's not letting the blood flow into the ventricle. If it sits there, it's going to clot.
But they're still perfusing.
They're still perfusing, but they're not having the complete emptying of the atria because the atria just simply aren't functioning properly. They're not doing what they should be doing, completely emptying so that the blood can flow through the ventricles and into either the aorta or the lungs. That it's just not functioning how it should. One of the most important considerations in atrial fibrillation is stroke risk. That was literally my next thing. Because the atria are not contracting effectively, the blood pools and form clots. So now we need to implement what? What medications? Anticoagulation. Plavix, Xarelto, warfarin, all of these are used in atrial fibrillation. Which do we not like to be used though? Out of those three? Warfarin. Warfarin is incredibly difficult to manage because so many foods or really physiologic responses can impact that warfarin level, and they have to continually be rechecked. Usually when they're starting out, they're rechecked about every week. The worst one I've seen, I had a patient that had changes to the warfarin, and I want to say they were at 8. Effectively managed, it should be at like 2. They were at 8.
So you look at them and they bleed?
Yeah, essentially. I mean, the risk for that person to either have an intracranial hemorrhage or to just cut themselves and bleed out is pretty high. Now, the last one, the last abnormal atrial rhythm is the PSVT, the paroxysmal supraventricular tachycardia. And it is a rapid, regular heart rhythm that stops and starts suddenly. And it's most often due to a reentry circuit in the atria where normal sinus rhythm is interrupted and there is an electrical loop that is consistent, but that rhythm is perfectly regular. The rates range from 150 to 250 beats a minute. And on the EKG, that P wave is present typically, but abnormal. Sometimes it's often hard to see because it kind of blends in with the T wave. The QRSs are usually narrow, And PSVT is significant because the rapid rate reduces ventricular filling and increases oxygen demand. The initial treatment in PSVT is a vagal maneuver in stable patients only. This is the Valsalva maneuver, where you tell the patient to bear down as though they're using the restroom, or they can blow through a straw. Both of those can initiate that Valsalva response, that vagal response. If this is unsuccessful in the stable patient, then we use the medication adenosine, which essentially stops the heart for a second, and then it restarts beating. I believe you can use up to 2 doses of the adenosine in the PSVT. Other options include beta blockers or calcium channel blockers. I have only seen the vagal maneuvers and the adenosine in practice. And if medications fail, or if the patient becomes hemodynamically unstable, or if they're already hemodynamically unstable, we have to cardioverse them. Now,
With the adenosine is a chemical cardioverter.
it's a chemical cardioverter.
So,
We would physically cardioverse them. We would use, do you remember in your simulation, you worked with the defibrillator? The defibrillator can also be utilized to cardiovert someone. So it delivers a shock at a set joule, a set electrical rate at a specific time. We're going to give it at the QRS. That's when the shock is delivered at the QRS. Now, abnormal ventricular rhythms. So ventricular tachycardia is defined as 3 or more consecutive ventricular beats at a rate greater than 100 beats per minute. The rhythm is usually regular, but the QRSs are wide and abnormal. Ventricular tachycardia can be sustained or non-sustained. Sustained VTach can quickly lead to ventricular fibrillation, hemodynamic instability, decreased cardiac output, and cardiac arrest. Stable VTach is a rate less than 150 beats per minute, and those patients typically have normal blood pressure and a palpable pulse, and those are treated with amiodarone first. An unstable VTach you treat with cardioversion if they're still communicative, if they haven't progressed on to VFib. In pulseless VTach, it is a life-threatening condition where the VTach is on the monitor but no pulse is palpated, and in this case, the patient loses consciousness and necessitates immediate CPR and defibrillation. Ventricular fibrillation, or VFib, is a lethal rhythm. It's characterized by chaotic, disorganized ventricular activity. There are no identifiable P waves. The QRS complexes are not identifiable, and the T waves are not identifiable. It very literally is just quivering. The ventricles don't pump blood, and this results in an absence of cardiac output. There is no cardiac output in ventricular fibrillation. Ventricular fibrillation is a medical emergency, and it necessitates immediate CPR, defibrillation, and 2 minutes of high-quality CPR, chest compressions. Then you analyze the rhythm and see if they need defibrillated, and we administer epi every how many minutes?
3 to 5.
3 to 5. Every 3 to 5.
So if they have VTach, that they have a pulse, our first action is not to shock, but what's our first action if they are in a VTach, if they still have a pulse and they're perfusing?
If they still have pulse and perfusing, the text recommends amiodarone first,
Okay.
because it's the
And that's called stable VTach versus unstable is pulseless?
unstable is where they're not hemodynamically stable. They're not having alterations in their blood pressure.
Okay.
They're not having alterations in their cardiac output.
Okay, which includes pulseless VTach, but not.
Yeah.
Okay.
And then I put this one in here very specifically for you because you asked about Trissades with Nathan. I don't care anything about Trissades. I've never seen Trissades in practice. Like, you probably are never going to see torsades unless you work cardiology. Torsades is a polymorphic ventricular tachycardia marked by rapid heart rate and twisting of those QRX complexes that are from a prolonged QT interval. This rhythm causes hemodynamic instability and may progress to ventricular fibrillation and sudden cardiac death, though it can sometimes terminate spontaneously. Torsades is linked to prolonged QT intervals, so medications like Zofran can actually cause a prolonged QT interval, which actually places the patient at risk for developing torsades. And treatment includes beta blockers for rate control and magnesium to stabilize the membrane and then potassium. And that's all I'm saying about torsades, and I'm not going to test you all on torsades. That was specifically for Caleb. All right, cardioversion versus defibrillation. What's the difference? Is there a way to move that down? I feel like y'all can't really see cardioversion versus defibrillation. It's fine. So cardioversion, the purpose is to restore a normal rhythm. We are doing this for patients that are in atrial fibrillation, atrial flutter, supraventricular tachycardia, and stable ventricular tachycardia. So these patients are usually conscious. Do we use sedation? Yes. Why do we sedate these patients? Because it is going to be very uncomfortable to be shocked with electrical activity, and they're not going to like it. We time the shock, so it's typically at the QRS complex. That's when you cardiovert someone. If you cardiovert them and you shock them anywhere else, what can happen?
Stop it.
You can stop their heart. Yeah. You can kill them. Defibrillation is to correct a life-threatening arrhythmia. That's pulseless VTAC and ventricular fibrillation. That is the only instance that you can use defibrillation. That's it. Know those. Know those moving forward. That is very NCLEX testable. It's not synchronized. It can be delivered whenever. The patient is usually or always unconscious. They're pulseless. They're not going to be responsive, and you deliver it immediately. So you see VFib, you can defib, VFib. So what are we going to do for these patients after they're cardioverted or defibrillated? You're going to monitor their vital signs. You're going to assess their airway for patency. You're going to get an ECG to see kind of what their rate and rhythm look like now. And you're going to look for level of consciousness and check them for burns. Why would they be burned?
Just shock.
You're shocking them with electricity. That's why we don't let patients in surgery wear jewelry. Jewelry can cause an arcing of the electricity. So as can the cautery that they use in surgery, also jewelry can. Arcing means the electricity essentially connects and then burns them across the chest. Complications that can result from cardioversion can include a dislodgement of blood clots from the chambers of the heart that can cause a pulmonary embolism. This would be evidenced by shortness of breath, chest pain, air hunger, decreasing O2 stat. It can cause a cerebrovascular accident, as evidenced by altered level of consciousness, slurred speech, and muscle weakness. And then it can also cause a myocardial infarction, which would be present with chest pain and ST elevation. Nurses need to make sure that they're providing therapeutic anticoagulation as ordered for individuals that have the dysrhythmias. That would be what, atrial fibrillation, right? We want to make sure that we're anticoagulating those patients. Cardioversion can also actually damage the heart tissue and impair heart function, resulting in decreased cardiac output and heart failure. That would present with hypotension, syncope, increased heart rate, and heart failure, which includes symptoms like shortness of breath, productive cough, peripheral edema. Now on to the heart walks. I feel like these are the rhythms that intimidate all nursing students, right? Yeah. So the heart block occurs when there is a problem with how electrical impulses travel from the atria to the ventricles through the AV node. When conduction is impaired, the PR interval becomes longer than 0.2 seconds. Your PR interval, this, that becomes longer. So look at the top one. In first degree AV block, all atrial impulses are conducted to the ventricles, but they are conducted more slowly than normal. On the EKG, the PR interval is longer, and it's consistently longer. So it's not getting longer and longer and longer. And heart block number 1, first degree heart block, that PR interval is consistently prolonged. It's not changing, it's just long. In second degree heart block, this occurs when some atrial impulses are conducted to the ventricles, but others are blocked. This results in intermittent dropped beats. There are 2 types of second degree heart blocks. So in Mobitz type 1, which is top right-hand side, this is called Winkie-Bach, and the AV conduction progressively slows until one P wave fails to conduct. So there is a gradual lengthening of the PR interval followed by a P wave that is not followed by a QRS. So we're getting longer and we're getting longer, we're getting longer, then we drop the QRS. So if you look, the P wave is already prolonged. So here it's long, here it's getting longer, here it's getting longer, and then here we've dropped the QRS. So here our P waves are consistently long, but we're not dropping anything. Here, the PR interval gets longer and longer and longer, and then we drop the QRS.
Are you saying the time between each PR interval?
Mm-hmm. Do you see how it's widening?
Yes.
So if you look, it gets wider and wider and wider, and we drop. It's already prolonged, but it just gets longer and longer and longer.
Not the time between each PR interval itself. So if you look at the first one, the P is right for the QRS, the next one is a little ways away, and the next one is a bit longer, and then you drop it. And then you start over with really close, P's right next to it.
Okay.
So that PR interval is getting longer each time it's getting dropped. And then it starts over.
Mobitz type 2 is more serious, and in this conduction delay, the conduction fails below the AV node, usually in the bundle of His or in the Purkinje fibers. And because of this, conduction is all or nothing. So there is a constant fixed PR interval, but there are suddenly dropped QRS complexes, and those QRS complexes are typically widened. So Mobitz type 2 is clinically dangerous because it can progress quickly to complete heart blocks. And in the complete heart block, the 3rd degree heart block, there are no atrial impulses that are conducted to the ventricles. So the atria and the ventricles are being controlled by separate pacemakers, and this is known as AV dissociation. Some common causes of 3rd degree heart blocks can include infarction, digitalis toxicity, or some age-related degeneration of the conduction system itself. And those P waves and QRS intervals, it's just not talking to each other. They're occurring randomly. And that requires the placement of immediate pacemaker. So in 1st degree heart block, we typically manage that by observation only. We don't have to intervene. Mobitz type 1, it's usually benign unless that patient becomes bradycardic or unstable. In Mobitz type 2, they require pacing, especially if they're unstable, if they're hemodynamically unstable. And in type 3, they have to have a pacemaker because they have no cardiac output there. I mean, their cardiac output is so low that they're not perfusing.
Are you saying 3rd degree, not
Yeah.
type 3?
3rd degree.
Okay.
Yeah,
So what do we do for someone in a complete heart block?
that's 3rd degree. Complete is 3rd degree.
Yes, what, like, is it We're not shocking them.
They have a pacemaker placed.
Okay.
They have the implantable pacemaker. They can be paced externally until they go in to receive the pacemaker.
Got it, so we're pacing them.
Yes,
That's what
we are
we're doing
pacing
with
them. That is correct. So I don't know if you all have ever had this shared with you. Have you all seen this before? No. Okay. The heart block point. If the R is far from P, then you have a first degree. Is that consistently far? Longer drop, then you have leaky box. So in second degree, P, R interval is longer, then it drops.